Hey folks, Scott Weingart here, and this is the EMCrit. So today on the this is part 2 of our physiology of shock, our hemodynamic physiology discussion. Part 1, which was members only, I gave an introduction to 2 papers, the 4 interface model by Phil Rolla, various other authors, including Rory Spiegel. Those 2 are our guests today. I went over Sarah Krager's paper on shock physiology, and that will provide a fantastic introduction to the episode you're about to hear. Now, if you are not a member, then the easy answer is become a member and go listen to that episode. But if you're not willing to do that right now, then you need to read the paper. And I link that in the notes for this episode. Read the 4 interface model paper. And because without one of those 2 things, either the previous episode or reading the paper, this is going to be a little bit confusing. I think you'd still get a bunch out of it, but it would be so much better if you just quickly peruse the paper or listen to the episode, or the smartest move, do both. Because what we're going to hear is 2 of the authors from that paper discussing some nuances and some hidden points. And I think you're really going to love it. Now, Phil asked me to pitch the conference that goes along with that paper and this entire new idea set for dealing with physiology at the bedside. And it's the Hospitalist and Resuscitationist Conference in September 2026, Montreal. It is the who's who of people doing the cutting edge work in clinical physiology for critical care and emergency medicine, and hospitalists, obviously. So take a look. It's linked in the notes for this episode, and you could see all the great stuff. I'll be there. That's the only reason I'm pitching this, is I will be there. And I'll be talking about the physiology of pre-oxygenation, the thing I obsess over. So I think you'll really love the conference. Go check it out. On the EMCrit front, still selling tickets for Reanimate, though not many left. If you want to come to Reanimate, buy tickets now. And we are coming close to selling out the Unburnable course, which is our anti-burnout course. And you could find the links for that stuff at emcrit.org/stuff. All right, let's get into the episode with Phil Rolla and Rory Spiegel. You guys introduce yourselves. Who are you and what do you do? Just in case people haven't heard you on the podcast 100 times.
Hi, thanks for having me, Scott. I'm Philip Rolla. I'm an internist who loves critical care. I work chief of the ICU at Santa Cabrini Hospital up in Montreal, and I've been collaborating with these 2 guys for a long time. And I guess my passion is resuscitation and trying to push the envelope on all things critical care.
Absolutely. And Rory?
Rory Spiegel. I do both critical care and emergency medicine. Formerly wrote a blog called EMNerd.
May it rest in peace.
Was an apprentice of Scott many years ago now. It's shocking how long ago now, but was your fellow.
What was the nidus of this interface paper?
It's hard to say. I think it was seeing that I think fundamentally, it's something that I think that what I'll consider good resuscitationists do, and that is looking at these 4 interfaces. It's just that I don't think that people were doing it in an organized fashion. And I think that in terms of teaching it, it makes a big difference. Rory, yourself, all the guys, and people were not resuscitating without looking at either the IVC or considering central venous pressure. We're looking at both RV, LV, and looking at tissue perfusion, cap refill, et cetera. And we have to credit, I think, Glenn's team for bringing capillary refill back to a center point. But I found that when I was trying to teach all this sort of mumbo jumbo to learners and fellows, it just became a lot of stuff that they had a hard time sort of prioritizing, putting together, where we debated, I think, in quite a while to figure out which were the interfaces that could really cause shock. And those were what we came down to. Those were the critical ones. And then once you make people go through, hit some checkpoints on every one of those, there's not a whole lot of missed stuff.
I think one of the niduses to build this was we developed Vexus, and then we kept having to explain where Vexus fits in and how to use it, and it kept getting misinterpreted. And we'd say, no, you have to look at everything, and that was somewhat vague. And so the idea was let's build Vexus into a greater model. And it's not reinventing the wheel. All of this stuff is somewhat taught in various ways, but it was how do we make this into a concrete model that's easily understandable and digestible?
I love it. Now, in my mind, you guys tell me if I'm wrong, the way this slots in is as a replacement of the preload, afterload, inotropy paradigm, which I think failed in a number of ways. First of all, it ignored the venous Vexus type stuff. It ignored the microcirculatory stuff. But it also really didn't clearly lead people to, okay, here's the way to assess those to make a real determination of whether the patient has one of those problems. And so it failed in those 2 regards. Is that the way you guys conceptualize this?
Yeah, pretty much. If you look at, I think what is mostly being done is people are looking at what's going on between essentially in the arterial tree. And then the next level, people at least take a look at what we term interface one and get an idea what the squeeze is like and all that. But for the most part, it stops there. And I think that's ignoring a huge part, and especially ignoring your cap refill as close as you get to tissue perfusion. So I think it's a matter of making sure people start to shine the light on those other interfaces in order to make sure that they have a coherent approach to their hemodynamics.
Yeah, and I should have said as well, the right heart is often ignored because a skilled intensivist, of course, they're going to throw on the echo, and it just happens naturally that they say, oh, that right heart looks like shit, versus what it should be, which is, okay, LV function, RV function, microcirculatory function, venous function. So I think it really pushes people to make the assessments. Now, Phil, I think Rory and I are going to gang up on you. We'll see if we could make a paradigm shift here. I think numbering the interfaces was not as beneficial as it could be because, first of all, the numbers chosen, I think, send people astray. And Rory said this during the wonderful conference you guys invited me to, and I felt that intuitively, I felt the same way, that you start with the microcirculation. It tells you so much. So, Phil, why the numbers, and can we get you to stray from the numbers and go to a more title-based system?
I totally understand that, and it does totally make sense. And I think if we could just like rewind back to when we first did it, fine, let's do it, no problem. So I think the problem is once we've got that core article out there, I think it's going to be more confusing to try to renumber the things. The other thing is that really perfusion is really not interface 2. It's really what's happening between interface 2 and 3. It's not actually interface 2. So I think it'd be hard to call that 1. Now, we could say that interface 2 and now becomes 1, and then whatever it gets numbered across. I would have been okay with it if it wasn't for the fact that we've already put it out there, and then now it's going to lead to, wait a minute, and more confusion.
Yeah, renumbering would be hard. Eliminating numbers entirely would be easy, but we'll leave that alone.
Yes, absolutely. But I totally think that in concept, when you're using it on a day-to-day basis, you don't need, it's just actually for communication between two that you need. How you frame it in your head really doesn't matter.
No, that's fair. Let's go back to bare bones. Let's talk about the 4 interfaces, and then we will talk about what I've in my mind called the interface squareds, which is the interface of the interfaces, which is where things really get interesting. But what I'd like to talk about is you folks at your course. All right, so at that course, the level of ultrasound skill required to really perform at the level that the instructors were was quite high. What I like you two to do is put yourself in the mindset of the average emergency doc or intensivist who may not have that same level of ultrasound skill, but they have some, right? They're not Luddites, right? They know how to do a basic echo. They know how to see the IVC. Let's start talking about the interfaces and how we would go about assessing them at that level, where they probably are not going to be doing a LVO VTI, but they certainly could get a qualitative assessment of the heart. And let's see how that slots in. So why don't we start with interface 2, which is the end of the arterial system to the microcirculation, to the arterioles and the actual interstitium. And so how do you guys go about assessing that? And obviously this one doesn't require echocardiographic skill at this stage.
Yeah, I think this is both the easiest and hardest one, right? One, because you don't need the ultrasound, but then it's requiring people to do a physical exam, which we've all lost the ability to do. But obviously the easy thing to say is cap refill. It's the most studied, but I don't think you look at it in isolation. I think you look at it with extremities, how cold or warm they are, modeling, so on and so forth. And you take all those things together and you make an assessment of whether you think they're uncoupled at the macro to microcirculation.
Phil, what is uncoupling? And I know, but I want you to give a concise definition to the audience because it comes up throughout this interface system.
Sure, yeah. This is an engineering and sort of computer science type of terminology where when, I guess, from a circulation standpoint, is when you're changing from one type of structural circulation to another, both have to have parameters and characteristics that make the energy transfer efficient. So if they start to become offset to each other now, The easiest one to think about is the interface 1, LV to arterial. If your afterload is too high for your ventricular capabilities, your end-systolic elastance or whatever you want to call it, contractility, then you're going to struggle to get efficient energy transfer. I think it's about having at that interface the two systems within their quote unquote normal-ish range so that energy transfers efficiently.
Yeah, absolutely. So I think you gave a perfect example. If you have a heart that wants to pump a bunch, but you have an afterload that's completely constricted down, then very little of that flow is going to be able to be transferred to that new pipe system, if we want to think about it in plumbing terms. All right. So do you buy, Phil, Rory's already stated cap refill as the primary, along with a global assessment of other stuff. Are we at the point where we could say cap refill is adequate to assess microcirculation?
Yeah, pretty much. I think it's a bit like the canary in the coal mine kind of thing. Obviously, you can have local issues for local circulatory beds that won't work. But basically, if your body hasn't decided to sacrifice the skin, then you can probably figure that the rest of the organs grossly are doing okay. But I completely agree with Rory. We're not just looking at just the cap refill of the fingertips. You put hands everywhere, look at the knees. I'll often look at, we're in Canada, sometimes cold in the rooms, look at chest, forehead, how does that cap refill going? Sometimes the real extremities are just too temperature sensitive in some places. Obviously, it depends where you practice.
All right. And if the microcirculatory function is good, then you could feel pretty good about the LV function, that at least it's meeting the cellular demand, but you could still have, if the patient's hypotensive, vasodilatory shock with still microcirculatory function intact. So that's the one to really add to the mix. Why don't we talk about interface 1, or that LV to arterial interface? So how are we going about assessing this?
So again, looking at this from the perspective of the frontline emergency physician who has some ultrasound skills but can't do everything, a cardiologist and more. I think the simplest way to look at it is take a combination of LV squeeze and how full the LV is. And those two things combined can give you a subjective view of what your cardiac output is. And I think when you add on top of that, your pulse pressure, which is also a pretty other simple thing to get an idea of how much of your blood pressure is created by cardiac output and how much is created by systemic vascular resistance. Obviously, there's some flaws in that. But using those three in combination, I think would give you a quick and dirty, easy way to assess how much of this cardiac output problem is the problem of too little blood or too little function.
Now, the key point to take, I think, from this that often gets ignored, even sometimes by cardiologists, which is weird, is that things like ejection fraction are load-dependent variables. That if you have a wide open afterload, the heart function is going to look gorgeous, and you're going to be injecting an enormous amount, and you might be lulled into the sense of security that the heart function is fantastic. And then you put the patient on vasoconstriction, which they need, and all of a sudden the heart function is garbage. But most people haven't reassessed that echo. If you get one, you feel pretty proud of the providers involved that they actually did that. But what we actually need is we need at least one when afterload has been normalized. That's going to really give us the mark of heart function.
I think one of the interesting points about that is like what you're interested in the moment is how good is your cardiac output with all the factors you have in that moment. And those can change at any given moment. And so all those factors that are independent of afterload aren't 100% predictive. And so I think it gave you an inkling of what will happen when you increase MAP at pressure or something, but it's not going to be completely predictive. So you're still going to have to look again and see how the heart's functioning when you've actually given the patient back a decent systemic vascular resistance.
All right, so far we're demanding at least 2 echoes for the initial resuscitation of the patient, preferably far more than that, but at least 2. So let's talk about the RV to pulmonary arterial interface. Now, you folks are recommending, in addition to visual assessment, something like TAPSE. Tell me, do we really need that, or is qualitative assessment enough?
So I think there is pretty good data that once you become comfortable eyeballing TAPSE, your qualitative assessment is as good as objectively measuring your TAPSE. And so I don't think that measuring it buys you that much more other than documentation and communication. I think measuring other forms of pulmonary hypertension actually becomes really useful. There's so many patients that I didn't realize how bad their pulmonary hypertension is until you actually measure like a tricuspid Rieger's jet, which is not qualitatively hard to do. But I think that's the point that adds a little more value when assessing the RV.
Phil, what do you think about that?
Yeah, absolutely agree. I think if I'm just quickly assessing someone, eyeballing that TAPC is more than enough. I don't actually measure IVCs but I do want it. I want my fellow or my resident to tell me a number for TAPC. I don't want them to tell me I look good. I want to know they measured it. So yeah, totally agree. On a simple management kind of thing, yes, quantitative is sufficient. Your ratios, TAPC is fine.
All right, I'm curious about this direct measurement of pulmonary hypertension. So give me a succinct understanding of what that would actually involve, and then I'll give you the ruling of whether that is okay for the lay provider or not. So what do you actually have to do in just looking at the tricuspid regurg jet, Rory?
What you do is you're going to put your color Doppler over the tricuspid jet, and typically you can do this. You can do this in both peristernal short, if you can get your high peristernal short view with the aortic valve in the middle, and then usually if you're in cardiac settings, your tricuspid valve is just on the left there, or your apical view when you can get a good view of your tricuspid valve and your Doppler signal is fairly parallel with it, which means you need a pretty on point apical view. A lot of times we get that pseudo apical view where we're still on the right ventricular wall, and then it's harder to capture a jet in the right alignment. But you get one of those two views, and then you're just going to put your color Doppler over your tricuspid valve and look for a regurg jet, which I think most of us have become fairly comfortable at this point. Obviously, you're just going to see a blue jet kind of going backwards in the wrong direction through your tricuspid valve. And then the part that I think people find confusing, it's not hard, but confusing, is switching from pulse wave Doppler to continuous wave Doppler. And I think the trickiest part is teaching people where to actually hit that button, right? But once you're able to switch that, then it's somewhat even easier because you don't have to really line up your gate. You just have to make sure you're measuring along the line of that tricuspid regurg jet, and you're going to get a flow, a velocity curve. And it's going to look somewhat similar to like a LVOT VTI. It's going to be going down and have a cylindrical view. And then you're just going to measure that peak velocity. And as long as you're in cardiac mode on your ultrasound, you should have the software. As soon as you measure that peak velocity, it's going to give you an estimate of the right ventricular systolic pressure right there, right? And then depending on what you believe, you add 10, 15, 20 millimeters of mercury to that, depending on what you think their right atrial pressure is. And it gives you some idea of a surrogate of pulmonary hypertension.
Okay. And that doesn't seem incredibly hard, but it speaks to the difficulty that I find in using and teaching this in all of these Doppler views, which is if you guide my hands and say, Scott, your alignment is right, yeah, I can do the measurements. That's not the problem. The problem is knowing what you're measuring is actually what is supposed to be measured. And that's always my fear. So speak to that, because I see learners in the course and the instructor's right there and they're like, oh no, a little bit, rotate, oh, turn that. And then, oh, okay, yep, and now measure that. But then in real life, where is the feedback that, yep, you're there or you're not? Because your fellow could give you a number, but you still have no idea whether that number has any relation to reality or not. How are you guys dealing with that aspect of it? They leave the course, they're now doing all of these complicated Doppler measurements themselves, but there's really no quality assessment whether those numbers are real or not.
Yeah, that's why a bunch of years ago, even before Vexus, before this level of complexity, when I started doing these ultrasound conferences in 2008, and people had come up after a couple of years. We learned, we were interested, but then we'd go back into their centers and there was even less people doing any then. And then they're just like floundering and then they forget what they learned. And then that's how we started. And I'm not trying to plug it at all because honestly, I don't have time, but we had these mini fellowships thing. And I've had people come and spend time with myself, a couple of other guys back in the past. I think there was someone who tried to organize something with Corbin and it just didn't work out. But it is good you have to spend some clinical time, like a micro residency, to see people doing it, to practice doing it, and to see people take decisions based on these things, and then the follow-up to what happens. So there's for sure there's a gap in there where I think that unless people work in a center where someone else is already doing some of these things, it is a little bit hard to take that leap that once you've learned this very basic skill to use it out in the fray. So I think, yeah, and I think the other thing is Twitter, Med Twitter, has provided people with a lot of cases that they see, and it's a bit more surrogate, it's a bit more removed from the actual case, but I think still useful to build experience around that.
I think that comes with any skill that we're trying to learn in medicine, right? You've got some people with a level of expertise that you don't have. And the question is, how much access do you have to them? But to gain competency in almost anything, you're not going to be able to do it in just a single day. So, like Phil said, you find someone, there's almost always someone local who knows how to do this stuff, and you find them and you have them look at your images. Even some of the echo techs, right? They can measure this. You can pull them aside, ask you to measure it with them, so on and so forth, until you get to the point where you feel comfortable that you're getting a reasonably accurate measurement.
You guys are on the cutting edge. It seems, if it hasn't already, AI in the next year will have solved this issue, because this is where it excels, right? This is like discrete, objective things that could be really either it could just do it. Like, I dream of the day I could just throw the Pope randomly on the chest and it's, yep, got enough. Or no, you guys, if you both have iPhones, turn your head for that initial Face ID thing. It's, oh no, you didn't do it enough. You got to keep turning. How far into the future are we talking where basically you just smear that probe all over the chest and it's going to obtain all the images it needs and spit out all this stuff without help? Should I spend the years gaining a high level? If I was a newly graduated fellow, should I do an extra year of hemodynamic echo assessment, or would that be a complete waste of time because it's going to be obviated 6 months from now?
I think it's not far away, but I think I don't know if you saw, there was a study that came out, I think I saw it flash on X today, about how, AI killed the boards, right? Like 95% or whatever. But then when they tested it in real life, quote unquote, it floundered, because there's probably some little cues that we're semi-aware of that we can pick up as humans that the AI can't. So I think there's going to be a time when, yes, you don't have to understand at all, and it will really tricorder it out for you, and you just have to approve, or maybe not even. It might be just informing you what it's doing. I think it's going to still take probably I would guess it'll probably take a decade before it's fully operational at the level that an expert can do.
That's interesting. I would predict. So EKGs, and you guys might argue, but I'd be pretty vociferous. EKGs were done. The EKG machine learning is better than any of us will ever be. And I say this as someone who spent a significant portion of my mental space learning ECGs at a level that I really wanted to get to. And now I put it through the machine and I'm like, anything I'm going to add to this is probably going to be false. And maybe Pendle, Myers, and Steve still have a slight edge, but I don't think that's going to last very long. So, Rory, do you think it's going to be 10 years or do you think it's going to be 10 months?
So I firmly believe we're a few years away from AI Judgment Day happening, AI taking over. So I don't think it'll be 10 years.
So we haven't done the thing that started it all, the Venus interface. So tell us about this. And then, is Vexus also undergoing any change or mutation is the second question I'll ask, because, hey folks, but we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening. I love to see the evolution of this stuff. So how do we go about assessing that Venus quadrant, and what have you guys streamlined over the past couple of years?
So essentially, Vexus is, I like to say, is looking at the relationship in the simplest form between the mean systemic filling pressure, or the venous pressure, and your right atrial pressure. And it's just grading the flow curves based on those two things. And so it's like Venus return physiology come to life. So for so long, we just estimated it, and there was no real good way of truly measuring it. And now, while we still can't measure a mean systemic filling pressure, we can look at flow curves and see what we think it is based on the difference between that and the right atrial pressure. And we look at it in three different venous beds: the hepatic veins, the portal veins, and the intrarenal veins. And usually you can capture all three looking over your liver, just going more anterior to more posterior as you walk around laterally over the liver, and you can catch all three of them. And I think as you get more nuanced, they all represent slightly different parts of your venous system. But essentially what you're looking for is going from normal flow for that vein to start seeing decreases in flow and then signs of actual flow going backwards through the venous system in the wrong direction.
I've always said, and you guys have not corrected me that I'm wrong, that if your IVC is not plethoric, then you don't have to actually start looking at those Doppler signals. Is that still being maintained?
I would say in 99% of patients, yes. There's a few cases like abdominal compartment syndrome or some reason that your intra-abdominal pressure is going to be higher than your IVC pressure, despite having really high right atrial pressures that you might miss some.
No, that's very fair. All right. This also is, I think, tough for the lay people to get these, to acquire these Doppler images and know they're measuring the right places. Is there anything you could conceptualize that would make VEXUS more obtainable?
As long as you know how to do a Doppler on ultrasound, I think it's actually a much easier study than looking at the heart. In fact, there's people that has no cardiac windows, and unless you have a TE, you're just not getting any views of cardiac function, that you can still get a VEXUS on, and you have some idea of what's going on, at least on your right side of your heart, by looking at how venous return physiology is occurring. But the big thing is, I like to get people to considering it's similar to a FAST and a gallbladder ultrasound, because they're somewhat used to imaging the gallbladder and used to doing that kind of fast view on the right upper quadrant, right? And those kind of get you in the right orientation. And then it's just about getting people comfortable with recognizing the different veins that we're looking at, the hepatic vein, the portal vein, and the intrarenal veins. And that just takes a little bit of orientation, and sometimes color Doppler helps showing them, because your portal vein and your hepatic veins essentially have different flow patterns on color Doppler. And I would say within 5 minutes, most people can feel pretty comfortable with identifying what's an hepatic vein and what's a portal vein.
No, I think that's fair. And finding the hepatic vein, for me, is the easy road to VEXUS, but it seems the least utile, the hepatic vein. It's the one that's most subject to artifact, and portal vein and renal are probably better ones to have in your quiver, but they are, at least for me, they're harder to get. But I guess you just got to learn how to do VEXUS. You're not going to give me an easy path once the IVC is large.
I think the easiest compromise, if you want one, I would, and Phil might correct me on this, but I think the easiest is the portal vein, right? It's the compromise of easiest to find. It's not as easy as an hepatic vein. You have a little more nuance of finding it, but it's relatively easy. And then interpreting the results without an EKG are pretty straightforward, right? I think the big problem with the hepatic vein is if you don't have EKG leads on, sometimes it can be difficult to kind of tell what's going on. And so the portal vein, the intrarenal is the hardest to get, the easiest to interpret, because you have the arterial tracing above with your intrarenal artery, but it's often hard for people to get. Whereas the portal, relatively easy to get, relatively easy to interpret. And so if I was to say VEXUS easy or VEXUS light, it would be your portal vein.
Right, that's fair. That brings up an interesting point. Most, at least in the emergency department, most people are not slapping on ECG leads. And yet it takes 5 seconds and it makes everything much, much easier. If you guys went down to your emergency departments, do they even have the ECG leads?
No. Scott, you were at Shock too, but when you were on the team that did those frees, right? You would be murdered if you didn't have the EKG leads on. So you kind of get into it, but you can barely keep the probes in the right place in the ED. I don't imagine they would reliably have EKG leads anywhere you could find them.
Are you guys manning your own portable ultrasounds, or are you relying on what's in the departments?
Yeah, I have my own portables.
And is that what you're using for most of these interface exams?
No, if it's someone in the unit, I push around my unit module, but I have my outpatient sort of palliative CHF clinic where I manage these people based on VEXUS and point of care ultrasound. So that I usually bring one of my portables for that.
Rory, you using whatever they have?
Yeah, so we have a standardized Sonosite throughout all our ICUs and EDs, so they're all fairly consistent. I also have a butterfly that I use on we do an ICU resus or triage shift where we kind of roam around the hospital evaluating sick patients, and so that's where I'll use a portable. But otherwise, it's a standard ultrasound everywhere we go.
We've spoken about the 4 interfaces. Let's talk about the interface of interfaces, because I think that's where this model gets really intriguing. So why don't we start off with the venous RV interface? So if the venous interface, quadrant 3, is good, what still has to be assessed in interface 4?
The thing is, obviously 1 and 2 are somewhat related, 3 and 4 are related. And the reason we had divided them is that, of course, interface 4 dysfunction is what almost always results in interface 3 uncoupling. But you can have someone who's uncoupled, usually adapted, but still technically uncoupled, maybe a big RV, et cetera, but either because they've been adequately managed or because they just had a GI bleed, they're not uncoupled at interface 3, which is why we wanted the distinction between the two.
Oh yeah, no, they have to both be assessed, obviously. But what I'm looking for is these shortcuts, these corner cuttings. And it seems if interface 3 looks good, then you could say they might have a chronic problem, but acutely that's not causing their shock state. Is that your understanding as well, Rory?
I think about it, and Phil spoke to it, that interface 2, if that's uncoupled, we usually look to either interface 1 or interface 4 as the problem, right? There's some reason that you're having a decreased cardiac output that's uncoupling your macro to microcirculation. But the opposite could be the case, that you have someone with just walking around with really bad LV failure, right? Like their cardiac output is awful and their ejection fraction is awful, but they're not uncoupled. This is just how they function in all day. And you're using interface 2 to try to get an idea of figuring out if this is something that they live with all the time and now they got septic, for example, or this is an acute problem or a combination of acute and chronic. And so I kind of look at the same thing with 3 and 4, where some can have really bad pulmonary hypertension or RV failure. But if their interface 4, and more importantly, their portal vein and somewhat their interrenal veins it doesn't show severe congestion, this is probably chronic, right? This is probably where they live. Now, the hepatic vein, that doesn't work as well, right? Because the hepatic vein, once they get that tricuspid regurg, it's almost impossible to normalize that hepatic vein, but the portal vein should normalize, right? And so I kind of look at 4 and 3 as that kind of way of trying to distinguish between acute and chronic, and then 1 and 2. And then the last thing I would say is the opposite is also true on the right side. You can have people with normal RV function, but as you start to fill up the venous circulation and you eliminate the redundancy of that circulation, you'll start to actually translate normal RV pulsatility back into your portal vein. And so you can start to see portal pulsatility by just venous congestion, just by volume resuscitating someone, even when their RV function is still normal. So they're intertwined, but not always completely connected.
I love it. The question we always asked 20 years ago was, how do you find the patient who is volume overloaded and in a shock state, and the ones you're going to want to diurese as you're upping their norepi? And that was just forbidden back then, because you just didn't have the hemodynamic assessment until you threw in a swan, and even then it didn't necessarily give you the answer. So how would you folks from an interface lens answer that question, who you're going to diurese in the midst of shock as you're upping their vasopressors?
I think that's obviously a higher level than basic question. And it was actually interesting because we were discussing that this morning on a patient with the fellows and residents. In the end, it comes down to, what's the septum doing? If my volume overload of my RV is shifting my septum over and actually now impinging on my LV preload, then I know, or I'm comfortable taking fluid off that patient. After that, to me, it becomes a gray zone, and maybe it's even good to remove volume because I'm just at interface 3, I'm tamponading my capillary network, and that it's in and of itself may help. Just decreasing mean systemic filling pressure may be good, but you're never sure, depending, especially if you have a patient with significant chronic pulmonary hypertension, hypertrophied RV, how much of that, pathological, but there's an element of necessity of the RV preload you need, it becomes a bit more of a gray zone. But if I'm seeing significant septal shift, then I'm comfortable taking fluid off that patient.
All right, that's a very fair answer. And obviously at that point, I think it's inarguable that patient needs diuresis. But I'm more curious about those gray zone cases, because that's where I really have these quandaries. Rory, how do you play this?
Yeah, I think one of the things you think about is what you're really looking at with your Vexus is the back pressure translating back to the organs, especially with the interrenal and the portal, where your organs are starting to see that venous pressure. And I think one of the things we don't often think about is in like a functional system, the organs usually don't see your pulsatility of your heart. right? And that's because you basically have Starling resistors that are built in, right? And the most obvious is the IVC. When it collapses, you're just not actually seeing the pressure going back to your organs. And that's why flow at the organs is mostly linear, right? You just have a monophasic waveform because they're not dealing with the shifting pressures of your right atrium. When you start to open up that venous system enough that you can actually start delivering pulsatility back to the organs, now all of a sudden your perfusion pressure is partially dictated by your CVP or your right atrial pressure. And so it's in cases like that when patients are in shock, and I think part of it is due to this decreased perfusion because of the increase in venous pressures that I'll diurese. And again, usually the portal and partially the interrenals, I feel better about diuresing them than simply hepatic alone.
How does the interface of the venous side and the microcirculatory interfaces 2 and 3 relate to that? So if you had a high vexus, is that going to cause further uncoupling of the microcirculation?
I think it's going to cause some uncoupling at that capillary to venular level. I think because of the vascular waterfall, it's not going to contribute to the uncoupling at that very sort of proximal end. But correct me if I'm wrong, you have other ideas. But definitely, as you increasing, and Kaninchi described that as some of his microcirculatory dysfunctions as a tissue tamponade, essentially, on top of obviously with the edema, the increased diffusion, et cetera, et cetera. But even just the tissue tamponade due to high venous pressures is well described.
Yeah, I think one of the things that probably the interface model somewhat misses is the difference between the macro to micro interface and the true perfusion at the tissue level, right? Because really the macro to micro interface is trying to figure out if your map is a reliable marker of perfusion, or if the level of the arterioles has clamped down and constricted, so your post-arterial pressure is no longer able to perfuse your organs. And that's slightly different than true perfusion at the organs, where your vexus or your increased venous pressure is going to become a problem. If your post-arterial pressure is low and your venous pressure is high, now your perfusion pressure across the organ has been lowered. And so they're slightly different. Obviously, they're often related, but you always want to think of, like, our end result is to think about perfusion, and these 4 interfaces are telling us where to identify the problems that might be occurring that are limiting perfusion.
So you two have taught this for a while. What questions come up in your learners that you think we should stave off the podcast listeners from having by addressing them here?
I mean, I think a lot of the questions that would come up are some of the reasons why we built it the way we did. And it almost, once you start to understand it in its totality, you get rid of or answer a lot of the questions like, is vexus just a fluid marker? Or can I use cardiac output or volume responsiveness to give fluid? And all those are answered optimally when you think about your interfaces and then you think about the therapeutics you're going to give the patient based on what you're seeing at your 4 interfaces. I think a few of the questions that come up a lot of times is just, and Scott, I think you saw it at the course, is like plugging these 4 interfaces together. Because we talk about each one and we talk what happens, but it really doesn't fall into place until you start giving them cases and showing them stuff and making them work through the 4 interfaces, and then they start to see how useful it can be.
Yeah, absolutely. I agree. All right, we're at the end here. What have we missed? What do you guys want to get across? You guys are the originators of this, so what do you want understood? I'm going to have people, hopefully, we'll see if they do it, read the paper before listening to this podcast. So people have now just finished reading it. What do you want to get across that may not have been discussed?
I think one of the main things is just seeing that this is conceptual and you can do it at different levels, which oftentimes people read through and say, oh my God, like you have to learn all these things to do. And like you guys were talking about, just these more quote unquote basic things, it's pretty good. If you've got a good pulse pressure, you've got a good cap refill time, you don't have a plethoric IVC, or you have a not high JVP, you're not in bad shape. So understanding that you can do this at different levels of sophistication is pretty good, depending especially where you are in your patient's trajectory and stuff like that, I think is important to understand, because you don't always have to have all the gizmos and gadgets to get a pretty solid understanding. And I think that just that alone, if you're minded to it, and just unlike scenarios we see often with patients getting fluids poured into them despite the fact that they have a high GVP or they have a good pulse pressure and people just are not really paying attention to it. I think you can get a lot by just your basic plus a little bit of echo of ultrasound. You can get quite a bit of this.
Rory, I want to hear your conclusion in a second, but Phil just brought something up that I want to discuss, which is JVP, or I think it's the easiest ultrasound thing to get to see where jugular collapse actually occurs. That's within everyone's skill set. But yet the literature I've seen has shown a really variable accuracy for the things we actually care about. Are you guys using jugular vein level or ultrasonographic surrogate of that in any way in your practice?
No, I don't. I think if you don't have hepatic, portal, and renal veins, maybe it's useful, but all three of those are easier to obtain because you already have the cardiac probe and you're already looking. And obviously, the big variable when measuring venous flows in your IJ is just the level of the person's head and neck compared to the level of their heart. And I think it can give you some answers. I don't think it tells you much more than what you're already looking at when you see hepatic vein, essentially.
So Phil, you were one of them who mentioned it. How are you using it in your practice?
Yeah, again, I agree. I don't use it much, but it has happened that sometimes, hey, we've got bandages, whatever it might be. We've got a broken arm strapped, so we can't really get to the liver. And every now and then I've taken a look at it. But I'm often actually referring to patients sometimes just on the ward who we're not necessarily in the ICU or in the ED. And you look at someone who's breathing and they've got their jugs up here, they're sitting up. That's not a fluid tolerant patient. You're not going to fix any problems that she has by pouring in fluids. So I think in terms of people probably have more of these tools that they can already use than they realize, as opposed to just saying you don't have to be able to do RVOT Doppler and notching and tissue Doppler and all that to get the low hanging fruit, let's say.
Fair. All right, Rory, back to you. What, after reading this paper, do you want people to know or understand that we haven't touched on yet?
So I think what Phil said is probably the most important, that this is a concept, and we tried to pick the best compromise of simplicity versus the most information you're going to get, like the 80-20 rule. With 80% effort, you'll get most of what you want, and then the remaining is going to be a whole lot more skills that you'll need to obtain. And then I think the other two things that I think are super important is you're phenotyping shock and you're phenotyping the temporizing measures you're going to be using to resuscitate this person. But you still have to identify source control and figure out what's causing this and actual endeavor to fix that, right? Because we can kind of mess around all we want with hemodynamics, but if we never actually achieve source control, we're going to lose. And so I think that's probably one of the most important things. And then the other thing is, I think we're always looking for the holy grail of the yes-no answer, the dichotomous, give fluids, don't give fluids, diurese, don't diurese. And part of what we kind of stress with both Vexus and the interface model is this is a holistic kind of assessment of hemodynamics. And it doesn't end with yes, no, it ends with the risk benefit of everything you do, right? And so despite this being fairly covering almost all of the things you want to assess for fluid tolerance or risk benefit, you still have to put it in perspective of the patient in front of you, right? And I talk about this like the Bayesian theory on fluid assessment, right? Where this idea is you've got a pretest probability of risk benefit of fluids. You've got a test, which in this case is our interface model, that has some strengths and benefits, and that gives you a post-test probability at the end on whether you want to give fluids, whether you want to give pressors, so on and so forth. But if you're 19 liters of fluid into this patient, I don't care what what your interface model shows, the likelihood that next fluid bolus is going to help is significantly lower than the first two, right? And the likelihood it's going to harm are significantly higher. So just having that idea that none of this is going to be a yes-no answer. You still have to be a clinician and think about this in the totality of the patient in front of you.
Love it. All right. Anything to add before we go, Phil?
No, I think that loops it up well.
All right. Then why don't you add, Phil, a plug for the Hospitals and Resuscitations Conference?
All right. So listen, I think we have a lot of fun planning and especially being at H&R. Scott, I'm super happy you'll be joining us physically this year. We've put this together over the last, 7 years. And I think it's really quite fantastic because it's putting together both the faculty and the participants, I think, share this sort of common desire to push the envelope or to see what's around the corner and to really, I think it really celebrates precision medicine, physiology-based medicine at the bedside. Not that we're against all guidelines, but I think they have their rule in place. But I think especially when it comes to shock and resuscitation, respiratory failure, there's a lot more granularity to it than can possibly be in a guideline. And I think it would be near impossible to really create big RCTs in which that granularity can be properly explored. That's what we do at H&R, and I think that the collaborations of growth have been really fantastic. I know that for me, it is, yes, it's a great time to hang out with friends, but it's also super been motivating and keeps me hungry and eager to continue to learn, because you surround yourself with people who are really wanting to do what's next, to see what's next, and to really push the envelope. So I do hope that many of your listeners choose to come join us in Montreal next September. From the 17th and the 18th are the core dates for H&R. And we have some pre and post congresses that are always fun and interesting. And so I hope to meet you there.
All right. Come visit these guys in person. All right. Can't thank you both enough.
Awesome. Rory can put one in too. He's usually better.
All right. You want to say something about the conference, Rory?
So it's personally my favorite conference of the year. I call it Comic-Con for physiology nerds, because that's what it is. It's incredible, the passion and knowledge that comes to this conference, both in the speakers and the attendance. I think every year someone just shows up as a conference attendee and has pushed the envelope so much farther than any of us, and then becomes a speaker the next year. I mean, the most famous Corbin, right? Corbin showed up, our first H&R, had lost his luggage, showed up in a Hawaiian shirt and flip-flops, and it became quite clear that his vast knowledge of physiology outstretched all of ours, and now obviously he's a key member of the team. But Vexus wouldn't be possible without H&R. Interfaces wouldn't be possible with H&R, and it's just amazing to watch its growth every year.
Love it. All right. Thank you both.
Awesome. Thanks a lot, Scott.
Thanks. That was fun.
As always, promote dignity, relief, and warmth. Very rapidly, some current projects you may be interested in. The Awake and Aware Conference, Scottsdale, Arizona, February 2027. Its Kickstarter has sold out, so the conference is live. Unfortunately, you missed the super discounted tickets, but the full price tickets are now available, and I will tell you the link at the end of this discussion. But that conference was amazing last year. It will be amazing this year. The Out on Time course, it is our charting course, our malpractice avoidance course, our getting out on time course, feeling on top of your shift efficiency. The spin class, that is our vertigo and dizziness mastery class. It is to get you to the point where you will be eager rather than dreading picking up a dizziness chart. We have the Resus Leadership Academy. That is our online fellowship to take you from emergency medicine or hospitalist to aggressively potent resuscitation doctor. You will be the person in your department leading the game on resuscitation and acute critical care. The Unburnable course, that is our burnout prevention course, our finding joy and flourishing in your career course. That is a cohort online course, so it is done in real time, and it has been lovely. This is our 5th cohort. And then, last but not least, the Reanimate course. That is our eCPR, ECMO CPR, and resuscitative ECMO course. It sells out every year. If you want to come, the time to buy tickets is now, because every year I get people, 4 months before the conference, they're like, I really want to come. Well, guess what? You can't, because I told you for the 5 months before now that they sell out every single year. You should have listened. So if you want to check out any of that stuff, come to EMCrit.org/stuff. EMCrit.org/stuff. That's EMCrit.org/STUFF. So I've loved talking to you. I'll talk to you again soon. Scott Weingart saying bye-bye.